Our lecture today is about the CA bladder. As you know, the second most common malignancy of the urinary system, it is the CA bladder. So today we will discuss this title. Okay. At first, the incidence, the male to female ratio is 3:1, according to the causative agent of the CA bladder. So the CA bladder is the second most common cancer of the genital urinary system. The average age at diagnosis is 65 years. At the time of the diagnosis, approximately 85% of a tumor or the CA bladder are localized to the bladder, and 15% of it spread to regional lymph node or distant metastasis. So this gives an idea about the importance of the early diagnosis of the CA bladder, because we can cut or we can catch the patient at the early period, so we can treat it and get rid of this tumor. Risk factor on pathogenesis: the cigarette smoking, multiple substance or material present in the cigarette or in the smoke that secreted in the urine that lead to form consider most important causative agent for the CA bladder. It is the beta naphthalamine. It is the beta, alpha and the beta naphthalamine. Occupational exposure: patients who are exposed to organic and chemical as aromatic amines, aniline, dye, and beta naphthalamine usually include people who work in chemical, dye, rubber, petroleum, leather, and printing industries at the increasing risks. So when we introduce a case for you and we say it in the information or in the history of the patient, he is a worker in the dye or in the rubber or in the petroleum, leather, whatever the works, it consider a risk factor. So give an idea or give you a point for diagnosis or for the reach the diagnosis of the patient. Cyclophosphamide, cytoxane, it is a drug or it is a chemotherapy used for management of various type of cancer disease, and is increase the risk of the CA bladder. Physical trauma of the urothelium: as you know, the urothelium that line the urinary system, it is the transitional type of epithelium, and this with continuous physical trauma by chronic infection like the schistosomiasis, bilharziasis, as you know, it leads to accumulation of the eggs in the bladder, or it put its eggs in the bladder, and lead to continuous trauma and lead to formation of the what is called the sandy patch in the wall of the bladder, and this increase the possibility of squamous cell carcinoma of the bladder. At the same things, in the presence of the chronic instrumentation like the Foley catheter, and also the calculi that increase the risk of malignancy. Diet: in general, Mediterranean diet has the low risk for urothelial cancer risk due to the increase the ingestion of fruit, vegetable, specifically citrus, apples, tomatoes, and carrots. It has decreased the incidence of the CA bladder. but the increase the or the industrial countries diet mode of life lead to increase the incidence of CA bladder. Genetic changes include activation of the oncogenes and loss or inactivation of tumor suppressor genes. So it is equilibrium between the tumor, between the oncogene and the tumor suppressor genes. So when we have activation of the oncogene, it leads to formation of a tumor, and the vice versa, when there is loss or inactivation of the tumor suppressor genes, at the same time it leads to increase the incidence of the tumor. Loss of the chromosome 9 appear to be consistent find in all stages or grades of the CA bladder, suggested early event in the CA bladder development. More recent studies examining the P53. P53, it is very important also in the consider tumor or consider oncogene in the consider tumor suppressor gene. Sorry, it is a tumor suppressor gene, and the mutation of this lead to formation of the tumor. So now we will go for the staging of the tumor. We depend on this paragraph. So at first we see the carcinoma in situ. Carcinoma in CIS mean carcinoma in situ. There, if you see this, the anatomy of the bladder, you see the inner layer. It is the epithelium. After the epithelium, it is the lamina propria. The lamina propria. This is the lamina propria, and after that there is the muscle coat. The muscle coat, three layers of the muscle coat. It is the inner longitudinal, middle circular, and outer longitudinal detrosal muscle. And after that is the subserosa and serosa. So it is the layers of the muscle, layers of the wall of the bladder. So when we have a tumor line to the or confined to the urothelium, and then go deep for the wall of the bladder. So at first we have carcinoma in situ, CIS, and then TA, as you see on the diagram. TA, it is within the epithelium. T1 within the lamina, T1 reaching the lamina propria. T2A superficial detrosal muscle. T2B detrosal muscle, deep detrosal muscle, and T3A microscopic invasion of the perivesical tissue. T3B macroscopic invasion of the perivesical tissue, extravasated or extravesical mass, and T4A invasion of the prostate, uterus, and vagina, and T4B invasion of the pelvic wall and the abdominal wall. So it is the staging system of the urothelium. It is the staging system of the urothelium. From this diagram, we see the carcinoma in situ, CIS, and then TA, and T1 and T2A consider something as a superficial tumor, but when reach the T2B, it's considered a deep tumor. T2B, T3, T4, it is a deep metastatic tumor. Okay. And now go for the grading. Grade 1, it is a well differentiated. Grade 2, moderately well differentiated. Grade 3, poor differentiated, and 4, it is a non-differentiated. Now we go for the histopathology. 98% of all bladder cancer are epithelial malignancy, with most benign being transitional cell carcinoma. Sorry, it is the most being transitional cell. So it is the most common type of a tumor that invade the urothelium. It is the transitional cell carcinoma. Normal urothelium. The normal urothelium is considered or is composed of 3 to 7 layers of transitional cell epithelium. I now repeat the epithelial lining of the urinary system. It is called the urothelium. Urothelium. It is a transitional type of epithelium called the urothelium. The normal urothelium is composed of 3 to 7 layers, transitional cell epithelium resting on basement membrane. Beyond the basement membrane is loose connective tissue, the lamina propria, in which occasionally smooth muscle fiber can be identified. These fibers should be distinguished from deeper, more extensive muscle elements. The muscle wall of the bladder is composed of muscle bundle coursing in multiple directions. As these converge near the bladder neck, 3 layers be recognized: inner and outer longitudinal, as I said, and the middle circular layer. B. The papilloma. Papillary tumor with a fine fibrovascular stalk. Papilloma are a rare benign condition, usually occur in younger patients. C. Transitional cell carcinoma. Approximately 90% of all bladder cancer are transitional cell carcinoma. Carcinoma in situ is recognizable as a flat anaplastic epithelium. It is the characteristic of carcinoma in situ. It's very important. What is the character of the transition of the carcinoma in situ? It is a flat anaplastic epithelium. Flat anaplastic epithelium. Non-transitional cell carcinoma. Now we get other types of the tumor that invade the wall of the bladder. One, it is the adenocarcinoma. Less than 2% of all bladder cancer, they are mucus secretion and may have glandular, colloid, or signet ring pattern. Squamous cell carcinoma, 5% and 10% of all bladder cancers in the United States, and is often associated with history of chemo infection or bilharzia infection, vesical calculi, or chronic catheter use. It is the most common type in Egypt and causing higher mortality rate in that country. Why? Because there is multiple infection of the bilharzial infection in Egypt. Undifferentiated carcinoma, rare, accounting for less than 2%, have no mature epithelium. Very undifferentiated tumors with neuroendocrine feature and small cell carcinomas. tend to be aggressive and present with metastasis. Mixed carcinoma. 6% of all bladder cancer are composed. 6% of all bladder cancer are composed of combination of a transitional glandular, squamous, or undifferentiated pattern. The most common type compresses the transitional and squamous cell elements. So mixed type of the transitional or of the bladder tumor composed of multiple type or multiple tumors, but the most common transitional and squamous element. Okay, clinical feature. Hematuria is the most common presenting symptom of the bladder cancer. About 80 to 90% of patients present with microscopic or macroscopic hematuria. Frequency. Lots, as I said in the session. Lots, it is the lower urinary tract symptom. So some patients present with lower urinary tract symptom. Frequency, urgency, dysuria, and hystency, plus minus hematuria. Okay, and also the patient may present with irritative voiding symptom, more common in patients with carcinoma in situ. So a lot of patients come and complain from irritative voiding symptom, and we may lose them because the symptom come look like UTI, so the patient complain from lots and rarely, and also complain from hematuria. Also, passing a clot or necrotic tissue tumor per urethra, suprapubic mass or pain, obstructive uropathy, and distant metastasis. Usually symptoms of advanced disease, including the bone pain or from bone metastasis, and also a flank pain from the retroperitoneal metastasis. Okay. Investigation. As you know, we start with the simple, non-invasive and non-available investigation. So start with the urine analysis and urine cytology. Send the patient for urine cytology, and sometimes we may find a tumor cell in urine in cytology. Usually reveal RPC in urine, pyuria, maybe due to, and pyuria may be due to concomitant infection, and also with hematology we may find anemia due to the chronic blood loss or invasion of the bone marrow, and also the increased blood urea and serum creatinine because of obstruction. Radiological finding, as you know, we start with the ultrasound and then IVU, CT scan, and MRI, but the diagnostic modality, it is the CTU or computerized tomography with contrast study, and so we find the tumor. Also, sometimes or all the patient need for the cystoscope or cystoarthroscopy and the tumor resection and getting biopsy for the diagnosis of the tumor. Treatment. Superficial bladder tumor, transurethral resection, plus intravesical chemotherapy. Chemo before the immuno. So please change it in the lecture or correct it. It is a transurethral resection. Transurethral in semi TURT, transurethral resection of the tumor. and intravesical chemotherapy, and then immunotherapy. Partial cystectomy and radical cystectomy all give the same prognosis, therefore treated by start by transurethral resection of the tumor because it has less morbidity and no need for urinary diversion as in the cystectomy. So at first we start with TURT for removal tumor, for get an idea, set for histopathology, and then start by treatment by intravesical chemotherapy, and then follow up the patient. Sometimes we need to treat the patient by radical cystectomy. Radical cystectomy may indicate it in superficial tumor if it is extensive. So this is the criteria and the of the patient who need radical cystectomy from first. If it is extensive, multiple superficial, large tumor, or large intracavitary tumor, and also high-grade tumor, grade 3 or above, and rapidly grade 2B, grade 2B go for radical cystectomy. Grade 2B go for radical cystectomy. Grade 2B, grade 3, grade 4 need for the radical cystectomy. Rapidly recurrent tumor after resection or recurrent in high grade. And also tumor amenable to endoscopic resection, tumor in the anterior wall. So tumor, large tumor in the anterior of the bladder, it is difficult to do TURT. So sometimes we go for resection either by partial cystectomy or by radical cystectomy. Also, when we have a deep tumor, deep bladder tumor, usually treated by partial or radical cystectomy. Partial cystectomy, this is the criteria of the partial cystectomy, who the patient amenable for the partial cystectomy. When there is a single tumor, located at the dome of the urinary bladder or the fundus or lateral wall, and give us a space so we can get a safe margin. This is the criteria of the partial cystectomy. Single tumor located at the dome of the bladder or in the lateral wall, but away from the ureteric orifice, so we can get a safe margin when we do resection. As you know, the radical cystectomy, it is the treatment of choice for the patient with a deep bladder, CI bladder from T2B and above. And during the radical cystectomy, we remove the bladder, bladder neck, prostate, and the perivesical fat, and also in female we should remove the uterus and do hysterectomy, oophorectomy, remove the uterus, the cervix, the anterior wall of the vagina or vaginal vault. The most common urine diversion it is the ileal conduit. Please correct this, ileostomy to ileal conduit. Please correct this from ileostomy to ileal conduit. Ileal conduit. So when both ureters anastomized to one end, anastomized anastomosis of the both ureter to one end of the ileum, we get a part of the terminal ileum after leave a distance about 25 cm. As you know, when we try to get a part from ileum, we should leave the last 25 cm because it is very important in absorption. So return back and then get the part of ileum about 20 to 25 cm length segment, and from this segment we either do orthotopic bladder by try to make a new bladder, orthotopic bladder or a new bladder from the ileum, or by do ileal conduit, and it is the most common and less complication. The most common and less complication, it is the ileal conduit. So when we say it, the most common type of the urine diversion, it is the ileal conduit. Ileal conduit, by anastomosis of the both ureter to one end of this segment we get from the ileum, and the other part or other opening of this segment connect to the subcutaneous or subcutaneously at the right lower quadrant of the abdomen. So it is the ileal conduit. Radiotherapy is an alternative to radical cystectomy in patients with deeply infiltrating bladder cancer, which is beyond surgery, and also patients who are poor surgical candidate due to advanced age or significant comorbid medical problems. So sometimes the alternative treatment of the cystectomy is the said it is the sandwich therapy. It is the chemoradiotherapy. If the patient not candidate for radical cystectomy, either because of his old age or old age related comorbidities, hypertensive, diabetic, cardiac problem, and we should think about the life of the patient and life-saving conditions. So we go for the radiotherapy treatment. Generally well tolerated, but unfortunately recurrence is common. Local recurrence is common. Also may be used as palliative therapy after radical cystectomy with recurrence or debulking surgery. Thank you very much. If you have anyone question, please.